So now we're going to reach our poster sessions, which is very exciting for us. I'm excited to introduce our first set of poster sessions. These are projects initiated by our colleagues to best serve our patients. And I'm going to announce in order of presentation. The hunger and agitation in the behavioral health setting poster will be our first. The second will be coordinated clinical supervision and inpatient behavioral health perspective. So our first one is Kevin Bryant, May Whitman, and Sarah Olstead. Thank you. Our third will be Francis Howard, myself, Amy Osborne, Lindsay Jasinski, Andrew Lane, and Jesse Wilson, and Sean Riley, sharing outcome measures for the Recovery Mall program evaluation. And finally, Liz Wallace will summarize neurocognitive profiles of individuals with schizophrenia spectrum disorders in an inpatient psychiatric setting. So I'm going to invite people up to the podium in that order. Please hold your questions until the end of all 4 presentations. You should have notebooks and pens in front of everyone. So if you have a question targeted to a specific presentation, just write that down and the title of the presentation so that you can direct that question to the correct poster. All right, so let's bring forward hunger and agitation. No, okay. We're going to ask you to speak from the podium, not from the lavalier.
Hi, my name is Sarah Kolstead, and I am the chair of one of Eastern State Hospital's professional governance committees. And our project for our committee was the reduction in afternoon seclusion and physical restraint minutes following the introduction of an additional daily snack. So the purpose of this was to see if adding an extra snack would reduce our physical restraint and seclusion numbers in the hours of 2 to 5 p.m. after the snack was initiated. Why is this important? Patient satisfaction goes up if we can reduce the amount of time that they're spending in seclusion and restraint. Staff safety also goes up. With staff members not involved in initiating restrictive measures, then there's less likelihood for injury. So our project was simple. We chose snack options to initiate on the unit at 2 o'clock. We originally piloted this on 1 unit, and for the time of the pilot, we saw a 98% reduction in physical restraint numbers in the pilot time. This is for the graph shows the time spent in physical restraint. After the success on the pilot unit, this was initiated hospital-wide, and the whole hospital in seclusion and mechanical restraint numbers saw almost a 50% reduction. That's all I've got.
Everyone. So we are really excited today to talk about coordinated supervision in clinical social work and give that from our inpatient behavioral health perspective here at Eastern State. So I am Lela Still, the Director of Social Work, and with me today is Carly Dickinson, who is a social worker all over and has been in multiple different roles and plays a huge role in clinical supervision at Eastern State Hospital. Oh, figured out the button. Okay, cool. So I wanted to just list the members of our clinical consultation group. So not everyone could be here for this presentation, but these 5 ladies are all, I guess I'm including myself, all amazing, wonderful, clinically strong, just really the backbone of the social work department and do so much for our hospital. So I'm going to give just a little bit of context into supervision, kind of the past and the present at Eastern State Hospital, and Carly's really going to jump into the meat of what our group has done. So LCSW Supervision was first established for ESH social workers back in 1988. So there were 3 individuals who were instrumental in that. One is Janice James, who is the current executive director at the Hope Center, local homeless shelter for men in Lexington. Also, Robert Walker in LCSW, and Donald Ralph, a PhD psychologist. So currently all of the social workers at Eastern State are required to have a master's degree. So we're all master's degree folks with also required the certified social worker CSW, and all the CSWs are working towards their LCSW. So we have several LCSWs as well, and the 5 of us that provide the supervision were listed on the previous slide. So all the social workers must participate in clinical supervision, and just kind of why that is important. I guess I can back up and say there's 2 kinds of supervision: administrative and clinical. So administrative is, you're the supervisor of your work, your administrative supervisor, and then clinical supervision is definitely a process of where you grow clinically and develop as a professional. So it is it's a process we take very seriously and have done a lot of work in thinking about. So social workers at Eastern State, so again, like I said, we are very clinical. We utilize a biopsychosocial model and do thorough psychosocial assessments, individual and family psychoeducation and therapy, and group therapies. And supervision is provided at no additional cost to social workers at Eastern State, and it's provided by Eastern State social workers. So this slide is just to show that it is a highly valuable benefit to employees. The average cost for paid clinical supervision is $100 to $150 an hour, and social workers must obtain 200 hours of supervision in order to obtain their LCSW. So the cost of supervision is valued at between $20,000 and $30,000. So since this is such a highly valuable benefit that we are giving, we want to make sure that that is a quality product that we are providing to our social workers, to support our social workers, because the ultimate goal is to have strong social workers, strong social work services, so we can have the best patient care for our patients. That's the ultimate goal. So with that, I'm going to turn it over to Carly to talk about the purpose of our group. Yeah, sure. I'll move so you can speak.
I always love when Lella and I get to stand next to each other. So our group really emerged out of some conversations that Lella and I actually had leading up to last fall. So we're really still in our infancy as a group, just regarding being clinical supervisors and the reality that some of the challenges I might be having are probably very similar to some of the challenges other clinical supervisors might be having. And it makes sense for us to have a format to discuss those together and have a space to share common ideas. So we recognize that we're all likely providing high quality clinical supervision already, but it would be beneficial to be more intentional about what we do and how we do it and why we do it. So I also think it's helpful to make a distinction between practice and activity. We really want to focus on, just like as clinicians, we want to be sure that we're providing clinical practice, that we're being intentional about what we're doing with our clients. It's based in theory, it's evidence-based, it's well thought out, versus activity, which I think emerges out of just the day-to-day busyness, burnout, those sorts of things, going through the motions. We want to be sure that we are practicing clinical supervision very intentionally. Go back. Sorry, not ready. We also want to provide mutual support to one another. Supervision can be a very challenging, it's a very dynamic responsibility. The Kentucky Board of Social Work tells us that we're essentially responsible for everything our supervisees do in their practice. So we need to help one another and help avoid burnout and stay effective and fresh. Also, Lela touched on this. We wanted to better maintain a balance between clinical and administrative functions, where previously those two levels of supervision had been essentially completely separate. We wanted to better integrate those. So where we have active treatment coordinators who supervise the two social workers on their unit, we recognize an opportunity for them to give clinical supervisors feedback and vice versa. And we'll talk about that a little bit more, what that looks like. So we really want to elevate the role of clinical social work in the hospital, the particularly unique perspective and philosophy that we provide to the interdisciplinary treatment team. All right, now you can move on. So we meet twice a month, sometimes more, sometimes less. There's lots of things that we have to talk about, and like Lela said, it consists of the 5 LCSW clinical supervisors at Eastern State. In order to be a clinical supervisor, you have to have your LCSW license plus 3 years additional clinical experience. Our meetings are very open-ended and collaborative. No one person is in charge. Anyone can bring topics. We do provide lots of structure, but we also want to provide some flexibility in what we discuss. It's also really important to touch on the fact that we do really want to maintain the confidentiality of our supervisees. So individual supervisees are not discussed in our group. We're focused more on different processes, patterns, those sorts of things that we're identifying in supervision. We also want to be very transparent with our supervisees, so they know we're doing this. Anytime there are issues that need to go beyond and be more specific, we're discussing that with them, which really should always be happening in clinical supervision. All right, so we've already had some pretty, I think, promising outcomes, and Lela will talk about future directions that we're looking at because, like I said, we're sort of in our infancy. We have seen a much higher degree of coordination between individual and group supervision where, the individual supervisees are coming to me and saying, hey, I think this might be a really helpful thing for you to talk about in group. And so I'm getting that feedback from them. And then I'm like, yeah, that's great. Gives me more to focus on. We have also enhanced the balance between administrative and clinical supervision, which has improved, we really think, patient care and outcomes. That's difficult to measure, but we're trying to figure out kind of some ways to do that. Obviously, if you're better collaborating as supervisors, you're going to be providing better supervision and better patient care, which is the ultimate goal for all of us. We also feel more confident in our abilities. I think it's very important to feel supported and to be able to bounce ideas off one another. There's not a lot out there in terms of what makes effective social work supervision, so we really are kind of trailblazing, I think, in this area. There's also we have, as of yet, not really found any other group that's doing this, so it's pretty exciting. I think it's kind of a visionary idea. And we've also implemented a process for the clinical supervisors to provide feedback during performance evaluations. So we're doing that this year for the first time, giving them some written feedback about what we're seeing in clinical supervision, strengths, and areas for growth for the supervisees. All right,
Okay,
next.
So I will finish this up quickly. Just some next steps. We're going to a conference later this month. I guess I should have done this at the beginning, raise it to my actual how tall I am, so I'm not hunching over. So we are also building a library of clinical supervision books. And again, we're more in our infancy, so definitely research is on the horizon. We don't have any hard data right now for y'all craving those numbers, but that's our goal, is to get that and to really show the positive outcomes from this project. So that's it. Thank you.
So we're going to be speaking as a group about the Recovery Mall Outcome Measures Project at Eastern State. And we will try to advance the slide. Oh, there we go.
Okay, so how do we do that?
Okay, so the presenters, Amy Osborne, Master's Level Occupational Therapist, Andrew Lane, TR, Jesse Wilson, Cassie Brown, LCSW, and myself, Frances Howard, Master Level Occupational Therapist. Okay. It's not working. There we go. So what is the Recovery Mall? It's Eastern State Hospital's award-winning recovery and rehabilitation program. It opened in May of 2006. Classes are offered in a centralized location on the first and second floor, provides recovery-focused treatment, and offers over 100 classes per week. Patients receive a schedule of classes geared toward their needs and preferences. So current development, I contacted numerous recovery malls across the United States to talk to directors to find out what they were doing. Are you looking at outcome measures? And basically the response was geared more toward tracking attendance. So we are the first, out of all the facilities I've contacted, we are the first to look at outcome measures. So it consists of recovery. Okay, let me back up a little bit. So the Outcome Measures Committee was formed in September of 2018, consists of recovery mall leadership as well as nursing, social work, and psychology. We have met weekly to provide structure, guidance, and support to teams of staff in developing outcome measures for the classes that we offer. And then we have been overseeing and piloting outcome measures throughout the recovery mall. So with current development, we'll continue with that. Staff who lead recovery mall classes have been educated about outcome measures and have begun to develop tools based on their group objectives. Currently, there are numerous groups in the pilot process, and committee members have put our direct values into action, and group leaders have really been energized by the opportunity to participate in this process. It's been pretty amazing.
This is still yours. So the purpose of the Recovery Mall program, evaluating the program, there's lots of benefits to evaluating the program. First and foremost, it improves patient care because it allows us to build on what is working and then to tweak those things that aren't working so great. It also helps us direct our resources to the programming that we find to be most effective. It allows patients and staff to give feedback on the groups, and then we use that group to further develop programming in the Recovery Mall. And then finally, it created a framework for us to evaluate patients' involvement consistently in the Recovery Mall. So when we were looking at what our outcome measures would look like for groups in the Recovery Mall, we realized very quickly that our diversified program was not going to work with a one-size-fits-all outcome measure. In other words, every group couldn't have the same measure. So instead, we developed a multifaceted approach to outcome measures that includes knowledge, attitude, behavior, and participation. So what that looks like, if you're doing a knowledge outcome, you're looking at the information they received during that group. Did they grow their knowledge or build their knowledge during that group? If you're looking at an attitude outcome measure, you're looking at their feelings and beliefs. Did they change because of the content of the group? If you're looking at behavior, that pretty much speaks for itself. Did their behavior change from the beginning of the group to the end of the group? And finally, we added this participation to the knowledge, attitude, and behavior model, but it is not simply did the patient come to the group, but what was their level of engagement during the group? So we have very succinct criteria as far as what is min, mod, max participation within that group. So that's the distinction there.
All right. So when we looked at kind of the process of developing our outcome measures, we looked at, obviously we're going to choose what we're looking to measure. We're going to develop the tool that we're looking at. We're going to get our supervisor's approval we will pilot that, and we will revise as indicated. And so when you're looking at, piloting these tools in groups, it's going to allow us to, see if the tool is going to measure what we're wanting it to. Often outcome measures do not give us the results that we want or that we expect. It's going to allow us to see what changes may need to be made. It's patient focused, allowing us to make these changes so that we can better meet our patients' needs.
So one of the things that we did earlier on in the development process was talk about how we're going to account for those days that we might have somebody in group who's experiencing really high symptom burden and it might be significantly disruptive to the entire group. Or days that the group doesn't meet because there's no attendance. How do we account for that gap in the data? Or days where we've got, a recovery mall party, so groups are kind of shifted towards that activity for the afternoon. So what we did as a group was we came up with what we feel is a pretty comprehensive list of fidelity codes. So if we have no attendance that day, I just put in that code for it so we know why there's that gap. And we really just want to make sure that it's encompassing everything that we might expect to encounter. So there's been a lot of what if discussion, but I think it's been pretty helpful so far. So right now, where we're at in the process is we've got several groups that have already begun the piloting. You can see the list right there includes DAE, our meal preparation group. We've got a sand tray group that's actually been piloting the longest, and they're getting pretty decent outcomes to look at. Jewelry making, library, positive outlooks, relaxation. So we've got several different types of groups, and that's really helped us develop what different types of outcomes we need to see. And it's been helpful as we go along for other staff to look at what has worked for these groups. Additionally, some of our PhD level psychology students have been setting up conference times with staff that might not be as comfortable or familiar with this kind of a process. And they've been meeting with them, giving them guidance, giving them support, kind of offering an objective look at what they could be looking at to measure, which is kind of nice because when you're like face deep in it for 8 hours a day, it's really hard to separate yourself from it and look at it as, just data collection. And right now, it's been a really positive impact so far. What we really try to do is make sure that it's incorporated into the workflow. It's not disrupting the group process. It's just a part of it, and it's a way for us to get that feedback as we go along. And we've heard feedback from staff that they're already thinking about other groups that they haven't piloted yet. I know myself personally, one of the groups I've piloted, I've found lesson plans that I've been doing for a while just weren't doing what they needed to do. So I've already been able to revise some stuff that I've been doing for years that I didn't realize wasn't as effective as I thought it was. You can see some of the data that we track daily. I've got a couple of examples of the graphs, and I actually want to give Cassie a chance to talk about DAE because her tool has been one of the ones that a lot of people have looked at as a good, thorough example.
So one of the things we looked at in DAE, back one. Okay, thank you. So one of the things we looked at in DA is we looked at what the purpose of the group was. DA is based on motivational interviewing principles, which means one of the things we want to look at is change talk specifically. So we looked at engagement as our first level of motivation. So are people actually engaging with the topic? Are they participating? Are they asleep? I don't always have the best teaching, right? Sometimes people are kind of checked out. It happens. Sometimes people are medicated or having difficulty engaging with the topic. So we want to look at engagement as our first level. The next thing we looked at was change talk. Are people saying the kinds of things that indicate they're thinking thoroughly and consciously about making changes in substance use behavior? And we wanted to measure that and capture that in an effective way. The last thing we wanted to look at was the participation. So were people actually engaging at a higher level, talking in the group? Were they offering perspectives? Were they asking questions? Were they demonstrating not just intention but interest in the topic? So we found that a clinician scoring process was one of the best ways to capture this data, because a lot of our patients are afraid to acknowledge where they actually are in the change process out of concern that they're going to be forced to stay in the group longer. It's going to extend length of stay. It's going to impact the way that the clinicians or the other patients look at them. So we found that a clinician scoring process was actually the most effective way to measure those items for our patients. All right, does anyone have anything they would like to add from the group? Thank you.
So hello everyone, my name is Elizabeth Wallace. I am a graduate student in psychology, and I've been a practicum student at Eastern State for the past year. So I'm going to tell you all about a research project at Eastern State. So it's neurocognitive profiles of individuals with schizophrenia spectrum disorders in an inpatient psychiatric setting. All right, so just to orient you all to a few threads that we're going to weave in eventually with this research project. So just a little bit of orientation. I'm sure I don't have to tell you all too much about schizophrenia. We're probably all familiar with that, but just a little orientation. So schizophrenia spectrum disorders, that includes schizophrenia, other psychotic disorders, and schizotypal personality disorder. And I'll refer to these as SSDs from now on just because it's kind of a mouthful. But SSDs, you need one or more in 5 symptom domains. So delusions, hallucinations, disorganized thinking, etc. And thinking about cognition specifically in SSDs, we know that cognitive deficits are pretty common in SSDs from as early as, symptom onset or illness onset. And these encompass broad deficits that can include trouble with attention, trouble with judgment, decision-making, kind of those frontal lobe functions, and also learning and memory are affected as well. And these cognitive deficits in SSDs are associated with poorer functional outcomes, so social functioning, occupational functioning, things like that. And kind of another piece, a thread that we're weaving together here is neurocognitive disorders. So, speaking directly to cognition, and, we can think of neurocognitive disorders as dementia syndromes. So they were formerly dementia, delirium, amnestic, and other cognitive disorders. And this is comprised of major neurocognitive disorder and mild neurocognitive disorder. And those are really only separated by functional decline. Is the person's activities of daily living intact or not? So one common assessment that is used to look at cognition is the repeatable battery for the assessment of neuropsychological status. So that's the R-bands. And it has a lot of benefits to use, especially in a setting like Eastern State, because it is brief, takes about 30 minutes. It's also repeatable. It has different forms. And it gives you 5 index scores across a variety of cognitive domains. So you can look at immediate memory, visual, spatial, constructional functioning, language, attention, delayed memory, and it also gives you an overall total score. So it's a commonly used assessment at Eastern State and settings like it. So the current study kind of weaving together all of those pieces of information. So we just wanted to look at further exploration of the specific pattern of neurocognitive performance in SSDs. So how do people with these diagnoses perform? How is their thinking? And the relationship between SSDs and NCDs, so neurocognitive disorders, are surprisingly, that relationship is kind of underexplored. The etiology of the dementia in patients with schizophrenia as they age, it's surprisingly not really well understood. So to do that, we did a retrospective file review, so from 2012 to 2019, and we looked at individuals who had a diagnosis of an SSD and were administered the R-bands. And that came out to 32 patients at Eastern State, and you can see some demographics under that. and noticed that over half of them also had an NCD diagnosis. All right, so really briefly, the main results we found. So you can see that the descriptives for our patients in the current study are in blue, and the normative data, so comparing it to a large study that's been done with individuals with SSDs, you can see that's in the orange. And our results lined up pretty well with that normative data. So you can see that, you know, the performance range for all of these different indices are pretty much the same. People are impaired where we would expect them to be impaired. And things like language are relatively intact, so in the low average range. One notable discrepancy we found was in this delayed memory. So in our sample, they were more impaired with delayed verbal memory than in the normative data. So hoping to explore that a little further and maybe thinking that this might be an area where the neurocognitive disorder might come into play, we did just a t-test between those 56% of individuals who had the NCD diagnosis and those who didn't. We did find that people with NCD diagnoses had lower scores on all indices except language, but those differences were not statistically significant. Overall, our results seem to be generally consistent with what we would expect given the normative data. But, we did find that lower than expected delayed memory. But there wasn't a significant difference between those with neurocognitive disorder and those without. So thinking about implications for practice, what do we do with these findings? This confirms again that SSDs are associated with significant neurocognitive deficits. And I think that's a really important takeaway, thinking about how do we interpret assessment results for people with SSDs. I think it's very important to interpret, any assessments you do with someone with an SSD in the context of, we're expecting them to be impaired in some areas, just on the basis of having that diagnosis. And definitely this points to the need for follow-up assessment in this population, especially as those with SSDs age, because again, we don't know a ton about that interplay between SSDs and NCDs. Limitation would just be how small our sample was. We only had 32 patients. So I see this as a good start, but we definitely want to get larger groups and maybe a comparison group, so people without schizophrenia diagnoses at all. All right, thank you.
Does anyone have any questions for any of the poster presentation groups? Yes. Who are you directing the question to?
I'm going to ask about the first poster. I was wondering if you had data before March, because I know in psych patients we tend to have big seasonal fluctuations.
We're constantly collecting that data, but I couldn't tell you exactly what it is pre-March. We did that, the professional governance group did that poster that we won the UK, Quality and Safety Showcase. We submitted it to the APNA conference, the state conference, and we're going to present it at the national conference. But that was specifically for that period of time. But those hours were always higher if you look at that data.